Patients that don't have an actionable mutation, that have advanced lung cancer, I think these patients obviously warrant systemic chemotherapy, and chemotherapy remains the standard of care for these patients. And I think, at least in my mind, the chemotherapy selection is still histology directed. For patients that have advanced adenocarcinoma, I think pemetrexed-based regimens with carboplatin are still considered the standard. And for patients with squamous cell, I think we have competing standards. I've been more on the carboabraxane front. I use that regimen more commonly than potentially carboplatin paclitaxel or carboplatin gemcitabine. So I think first and foremost, we have to look at the histology for patients. I think secondly, you have to look at the patient's performance status to see and understand whether they can tolerate a platinum doublet. And then also understand what the patient's goals are. I think we need to realize that these patients come in and unfortunately chemotherapy can't cure them. It can extend their life, and it's important. It can make them feel better, but I think we need to understand what the patient's goals are long term. So I would say looking at the histology obviously is important in selecting chemotherapy for those patients that don't have a driver mutation. Obviously, PD-L1, if that's negative, they're not going to get immunotherapy. I think we're going to talk a little bit later about the role of adding immunotherapy to platinum chemotherapy up front. But I think really histology, patient performance, tumor burden, looking at their symptoms, all of these need to be factored in when making a treatment decision in the treatment-naive patient. So in my mind, this is very controversial. We have a phase 2 trial that's been published of roughly 120 patients that was randomized to patients with advanced stage lung cancer with all PD-L1. It didn't matter what your PD-L1 was. There was no cutoff point. They were randomized to either carboplatin pemetrexed or carboplatin pemetrexed with pembrolizumab. And they were asking a question, can we add immunotherapy to chemotherapy in a non-select way and improve outcomes? And that trial showed a benefit in response rate. It showed a benefit in progression-free survival, but no benefit in overall survival. And we have a phase 3 trial that is already completed with the same design, Keynote 189, in which we'll have better answers off of a larger trial. In my mind, I would say I'm not using immunotherapy, pembrolizumab with chemotherapy yet. I think there are select patient populations in which we can consider it. In patients perhaps with a tumor proportion score less than 50, but in the, in the 30 to 50% range in which we're trying to elicit a response, maybe that's an ideal candidate. But for the most part, I haven't been using it yet. And I think the data will tell us. The phase 3 trial will be reported hopefully next year in second quarter 2018, and we'll have a better answer. Well, if immunotherapy added to chemotherapy actually extends survival, and that's what's important for me. So as of now, in select cases, I use it, but for the most part, I'm still sticking with just a chemotherapy backbone.